Habib Davanloo. We continue with the chapter on Habib Davanloo. In the first part, we have completed till question 15, and now we'll carry on from question 16. Question 16, what is the concept of affect moving into striated muscles and soft muscles? Davanloo observes that as affect is mobilized in therapy, in ISTDP especially, the affect moves in a particular way. And based upon how much affect is mobilized and what is the capacity of the person, how cohesive or fragile the person is, based on that, the affect moves in a particular direction. And usually it can be any affect, but usually we talk about anxiety and anxiety regulation. And especially with relation to anxiety, Davanloo talks about 3 categories of movements of anxiety. First, if the anxiety mobilized is mild and optimum, it moves into the striated muscles. May not be hands and legs, maybe other striated muscles, but essentially into striated muscles. So we say the patient is in striated, or the anxiety is in striated zone, which is the optimum zone to work in. Interestingly, we are not looking at no anxiety working, because the moment affect is mobilized, some anxiety is likely to be there. So 3 stages of anxiety. First, if the anxiety active is mild or optimum, we say it is in the striated zone, in which case it is felt either in hands or legs, or the clutching of the jaw, or slight tightening in the back, curling inwards of the fingers of hands or legs. Sighing is a very important sign of the anxiety being in the striated. Second level of anxiety is where anxiety is higher than striated. It is not optimum. It is higher than optimum, and it may go into soft muscles or smooth muscles. It may go into the stomach and cause a nauseating feeling. It may go into lungs and create a spasm-like feeling. It may create migraine-like headaches, inside-out headaches. So outside in usually are striated types, but the center out is more likely to be the soft muscle thing. So either anxiety can be of mild and optimum nature, quantum in nature, we say it is in the striated, or it may go into smooth muscles. Smooth muscles are involuntary muscles, whereas striated muscles are under the voluntary nervous system control. We don't want anxiety to go into smooth muscles, because that is something which will lead to psychosomatic problems. And if anxiety is very high, even higher than going into smooth muscles, it goes into what is called CPD, cognitive perceptual disturbance. So either the cognition is impaired or the sensory perceptual system is impaired. So either if the cognition is impaired, one can start going into the open split situation and start projecting. Paranoid projections, extremely aggressive and torturous projections. Or if the sensory perceptual system is affected, then one can experience blurred vision or jelly legs, the tone goes out of the muscle, or complete looseness of the body, or whistling in the ears, or a vertigo-like feeling. These are all impairments of cognition or sensory perception. So these are called the CPD. The anxiety is going into CPD. So when anxiety is mobilized, it usually is into these three zones. Either it is in the striated zone, which is where we want it to be, and this is the optimum state where we wish to work, or it can be going into smooth muscles, or it can go into cognitive perceptual disturbance. If the patient is going into smooth muscle zone or CPD zone, we have to stop the pace of our pressure, the pace of inquiry and pressure, and go into anxiety regulation, because these are unhealthy levels of anxiety, counterproductive levels of anxiety. So we don't want to be in CPD, we don't want to be in smooth muscles, we want to be in the striated. So if we are not in striated, we have to get into anxiety regulation to come back to striated. (17) Is the murderous rage and torturous rage experienced in therapy in transference? In most cases, yes, not necessarily always, but in most cases, yes. The patient feels irritated and angry towards the therapist as he presses for feelings, and then gets into an imaginative portrayal of torturing and killing the therapist. And later on, after seeing the tortured dead therapist, he usually moves on to see instead of the therapist's body of somebody very close to him, either the father or the mother. Mostly it is the father. And thereafter, the feeling of guilt, pain, and arise. Pain not only owing to what has been done, but some other deep-seated pain, because of which all this rage was there. And then positive feelings of love, concern, care, attachment, and relation, they come up. 18. Why do we always have to take this route of uncovering the murderous and torturous rage and then on to guilt? It is because of something very important discovered by Davanloo, that repressed rage can act as a defensive affective shield, which covers up and does not allow other effects and other material to come up. It is like a second layer of repression, almost a affective layer of repression. So we usually talk about the force of repression from the repression barrier. Apart from that force, this also acts like a quasi repression barrier. And most people are not comfortable feeling anger. They are comfortable feeling pain. Not as comfortable as not feeling anything, but relatively speaking, they are easier with pain than they are with anger, and least with guilt. Once this murderous and torturous rage is felt, the guilt is felt fully and experienced, and we let it go. It reduces, occasionally it eliminates all the self-defeating, self-sabotaging behavior. And one feels the energy which is liberated because of not being blocked into that guilt and rage, that energy is now available for positive feelings, positive enterprises, and we have a very vivid feeling of being alive, loving, and emotionally wanting to relate. And this is, of course, a state of healing and well-being. So that is why the feeling of rage is so important. How is ISTDP different from classical psychoanalysis? There are many points of differences. In fact, on many points, it's just upside down. You can just count the differences, some of the differences, there are many differences, but some of them are ISTDP is not based upon holding, it is based upon challenge and confrontation. It is based on face-to-face, not on the couch. Whereas psychoanalysis has a substantial amount of holding and is on the couch. Psychoanalytic sessions are usually 45 minutes or 1 hour or 50 minutes or 1 hour. ISTDP sessions vary from 45 minutes to 3 hours, and for the same person may vary, which is not so in psychoanalysis. In psychoanalysis, we keep the same duration and the same number of days per week. The first session in ISTDP usually is longer. The trial session may go up to 3 hours. In ISTDP, we don't go so much into revisit of events in an intellectual sense. We also don't go into the aspect of personal growth. We don't go into the aspect of self-exploration. The restricted and focused concern of ISTDP is catharsis of affect and restructuring. It does not go so much into self-exploration or personal growth. That's one of the reasons why it is short. Because in psychoanalysis, much of the time also goes into self-exploration and personal growth, apart from catharsis and restructuring. But the first two goals of self-exploration and personal growth, they go out of the window in ISTDP. We are just focused on two elements, catharsis and restructuring. Psychoanalysis goes very deep into dream analysis of free association and slips, whereas ISTDP does not go into it. In fact, ISTDP sees free association as a defense of free associating away from the core of the problem. So their take on the significance of free association, significance of dreams is completely different. In fact, I have done some interesting experiments of doing dream analysis using ISTDP. Is it necessary to do psychoanalysis before moving into ISTDP? Yes, ideally, yes. Legally, no. You can enroll into ISTDP program without psychoanalysis, but ethically and ideally, yes, because my own experience is those who come to ISTDP without having been through psychoanalysis usually become very fanatic and reductionist, and often they do more harm than good to the patient. 21. What is triangle of conflict? The triangle of conflict was suggested by Israel, and the triangle of conflict is a triangle of hidden feelings covered up by defense, and as we challenge the defense, the rise of anxiety. That there is some conflict involving important feelings, and the feelings are covered up by defenses. And as we challenge the defenses, the anxiety rises. 22. What is the triangle of persons? The triangle of persons was proposed by Dr. Malan and used by Davanloo. Davanloo has used two very important concepts. One is three important concepts: triangle of feelings, the triangle of persons, and the significance of creating a state of crisis. Because he saw that in crisis, the change becomes easy and lasting, as though the resistance is put to a side and the unconscious opens up for healing during the crisis. And then the whole question was how to recreate that crisis in the therapy room. So Dr. Malan's triangle is this, that the person is related to significant important parents, others, and the therapist. And in the triangle of persons, first proposed by Menninger and then popularized by Dr. Malan. In fact, most people call it as Dr. Malan's triangle rather than Menninger's triangle. And what happens in this triangle is the feelings towards the parent or others are transferred onto the therapist. And therefore, if you wish, you can create another triangle of the patient, the parent, and the therapist, or the patient and the other and the therapist. And this, in this triangle, the transference happens. And what is difficult to accept for X is experienced in relation with the therapist. So this triangle of persons is very important. Similarly, there is one more triangle of let us not confuse it, but just let us keep it to this, the triangle of persons, where from others and from parents, it's transferred onto the therapist. What happens when anxiety becomes too high to bear? Depends on how high it goes. If it is the optimum, the person size or experiences symptoms of striated, anxiety being in the striated muscles, which is optimum, which is what we want. If it goes higher, it can either go into smooth muscles or it can get into cognitive perceptual disturbance. We have seen before what happens in smooth muscles. If anxiety goes into smooth muscles or anxiety goes into cognitive perceptual disturbance. 24. How do you know you are operating within tolerable anxiety? The tone of the body, the perceptual, the cognitive presence of the person, absence of any pathological phenomena like the split or projection, the absence of any psychosomatic distress, and sighing of the person. Sighing is very important. Sighing of the person and the will of the person expressed very explicitly, they two are very important. And sighing especially provides a signature of being in the optimum anxiety zone. How does ISTDP deal with resistance, which prevents access to the unconscious feeling? One is focus. Second, bringing to the notice of the person the cost that he pays by not feeling the feelings. The cost-benefit analysis of continuing with the resistance, siding with the resistance. And then trying to be in the here and now and invite feelings towards the therapist. Finally, there is this persistence of, apart from focus, the persistence of challenge, and if nothing works, head-on collision. These are the ways the resistance is dealt with. It's partly cognitively dealt with, partly dealt with in terms of cost-benefit analysis of what is happening, partly it is dealt with by challenge, and lastly, if necessary, by head-on collision. 26. Do people feel sensations of energy, heat, building up like a vortex, etc. in different parts of the body during ISTDP? Yes, it has been very extensively documented and video documented, so there are no questions. One good part that ISTDP overcomes compared to classical psychotherapy is this getting empirical data on a video. So there are no ifs and buts, there are no doubts behind the scene. As the affect moves based upon which is the affect in question, what is the volume and how it is moving, it is felt at different parts of the body. Guilt is often felt in the chest area with some sensations of puking. Suffocation of sound or inability to speak out is often felt as lump in the throat. Deep-seated pain is often felt as lump in this area. Anger is often felt as rising anger. Anger is also felt as clutching of jaws. Anger is also felt as clutching of fists or fingers of the legs going in. So there is some predictability, that there is some commonality, there is some generality to it, that certain emotional movements are felt in a certain way. It is not just random person to person. There is some pattern. This pattern comes very close to ancient Indian and Chinese ideas, Tibetan ideas, of there being a circulatory system of energy having pipelines called nadis and chakras. Just as we have a circulatory system for blood, a kind of energy circulatory system, and there being emotional centers, energy centers, and therefore specific effects are felt at specific parts of the body, and then specific visual images are created, specific feelings are experienced, a specific type of movements are seen. So yes, I think this videography, if we keep doing it and keep exploring it even from a Eastern standpoint, Hindu spirituality, Hindu psychology standpoint, it will provide us an empirical proof of ancient Hindu sciences of the Tantra school, yoga school, and so many other schools of psychology and spirituality. 27. Does ISTDP combine useful elements from CBT and psychoanalysis as also from other therapies? Yes, it does. ISTDP draws very liberally from CBT, from CDT, from Freud, from Klein, from Kohut, also from acceptance commitment theory. It's just that ISTDP practitioners put up this facade of being theoretical. It's no longer theoretical. 28. How do I become an ISTDP therapist? Please visit the ISTDP Institute website for this. There are short duration introductory programs, and if you are You can start with that, and then if you feel interested, go for the core program, which would be a 3-year program to become an ISTD therapist. And thereafter, there are advanced level programs if you are further interested in becoming a teacher or an advanced level practitioner of ISTD. Who are the leading practitioners and theorists? Theorists aren't many after Davanloo. In fact, Davanloo himself is not much of a theorist. So that side is not very voluminous in this area. Practitioners, yes. Tom Broad, Alan Abbas, John Frederickson, Patricia, Workel, Alan Abbas, all of them are very well-known practitioners of ISTD. You can see their videos on YouTube. What are the resources I can access for learning more? Website of ISTDP Institute is the best source. There are research papers by Davanloo, research papers by Alan Abbas, books by John Frederickson and Patricia, and quite some research papers by scholars who have come much later but have produced very good material. Similarly, quite some material is there on EDT, experiential dynamic theory. With this, we come to the end of this chapter on ISTDP. Let us end with a statement from Habib Davanloo. The greatest resistance people show is the resistance to emotional closeness. Habib Davanloo. Thank you.